Hi, welcome to the Anti-Waffle podcast with me, Em and Marva Gregorio de Souza.
Hello!
And together we will try to talk about research without any gobbledygook. Each episode we'll be talking to a researcher who will discuss the work they're doing, looking at why this research is important and asking how did they get into this field. We hope that it will be informative and interesting and bring a bit of the academic world into the real world. This week we have Dr. Andrew Morley. He is the History and Archives Project Manager for the Physiological Society. Hi Andrew, thank you very much for being here.
Good morning.
Thank you very much for talking to us. Would you mind starting by telling us a bit about your research, please?
Yes, so my most recent research has taken me away from clinical research, which I used to do, and into a multidisciplinary area. So my project started, I suppose, 4 or 5 years ago when I was a Wellcome Trust Visiting Fellow at the Centre for the History of Science, Technology and Medicine at the University of Manchester. And I applied for and got a grant to fund a study called A Critical History of Anaesthesia, Intraoperative Critical Incidents at Guy's Hospital, 1955 to 74 and the present day.
Wow.
And
How did you come up with that title?
I think when you're applying for grants, and I have done many times, some of them successful, many of them not, I think you have to try and come up with something a little catchy.
Right.
I think that there's been a fashion in project titles and in book titles and in many other areas as well for the subclause. So you start with your attractive phrase and then you put an explanatory phrase afterwards. I suspect that this is now so common that the grant reviewers raise their eyes in horror every time they see it. But this was in 2014, so if not new, at least they probably hadn't seen quite so many.
Yeah.
So the project was sparked off really by some conversations I had been having with a medical historian. She and I had been co-applicants on a major grant from the Wellcome Trust, which we fell at the first hurdle on that one. It was a large interdisciplinary project about consciousness. I'm an anaesthetist usually, and so that was particularly interesting to me. We didn't get the money, we didn't get very far at all, but in the way that research often works, you develop links and friendships that lead on to other things. And some months after we failed to get the money for the consciousness research, I had the idea that I would like to try and do something connected with medical history. And I was particularly interested at that stage in the explanation of risk to patients. It's something that's done perhaps better now than it used to be, but still not done terribly well. And it's evident from the front page of the newspapers all the time that many times patients and relatives don't feel that risk has been explained in a way that they understand, or that they evidently have not perhaps understood fully what was being explained to them before a surgical procedure, for example. So I was quite interested in that area. While I was discussing this with Stephanie Snow up at the University of Manchester, I was talking to some of my anaesthetic colleagues, and one of my old bosses revealed that he had found in the departmental library at Guy's, when he retired, an exercise book with 120 handwritten incidents of things going wrong in the operating theatre between 1955 and 1974.
Wow.
So this is an extraordinary document, not least because featured prominently on the cover was the word incidents. And in fact, the term that is used or was used for many years to describe these sort of things was critical incidents. And critical incidents was a term, or the critical incident technique was developed in the mid-1950s by an American psychologist working with air crews to look at things going wrong there. So this document has got incidents on the front, and that's in 1955. And that's very interesting to me, because it was only in 1954 that the Americans came up with the term critical incident technique. So I had a book to start with. I applied for a grant, and the research was to take the form of some documentary research and archival research on the incidents in the book. But more significantly, as it turned out, a series of interviews, oral history interviews with theatre staff from the 1950s, 60s and 70s at Guy's, and a comparative cohort of staff from the present day. And the glorious thing is that it being the NHS, the operating theatres that the staff work in today are exactly the same as the ones that they were using from 1961 onwards at Guy's. So many of the incidents in the book and many of the incidents that my retired cohort talked about happened in the same geographical location, in the same theatres.
Wow. Oh my God.
So there are some great... I was very lucky because Guy's Hospital has a very extensive archive, which is kept at the London Metropolitan Archives up in Clerkenwell. And so they have minutes of meetings going back, right to the foundation. But obviously for me, I was sort of interested in those from the latter half of the 20th century. They have all the documents relating to the construction of the operating theatres, which were opened in 1961, and so there was an awful lot of and quite a lot of photographic evidence as well. One of the joys of studying the second half of the 20th century is that there's an awful lot of visual evidence. There's even some audio recordings and some videos and so forth, and so that all made things very interesting for someone who doesn't come from a history background.
Wow, that's fascinating. So did you, this book, this notebook, was that just someone somewhere heard about this critical incident recording thing and then just, let me make a note and just start and then...
Yeah, I think it's unlikely that they knew the term critical incident. I think probably it's a reasonable incident is a reasonable term to describe something going wrong, and I suspect that that's where it came from. So I don't think that the person who set the book up actually knew about the American research. It really didn't make its way into the medical journals until much later on. And the first sort of major studies looking at critical incident technique in the analysis of medical mistakes didn't happen for I think another 20 odd years. So they were a little ahead of the game. So we established who the head of department was at the time, and various things in the book indicated that he was probably the one responsible for establishing the book. There are many different hands in it, so it's the anaesthetists. It's anaesthetists who are recording their mistakes, and so there are many different hands in it. So the anaesthetists used to come back to the department, find a book, write down what had gone wrong, in the hope that people would learn from their mistakes. And so to my great joy, when I came to interview my cohort of retired anaesthetists, at least two of them had incidents in the book, and one of them remembered writing in the book back in the 1960s. So that was that was very interesting, and certainly made the interviews very enjoyable because there was something to focus on, and lots of discussions to be had. So.
Excellent.
And what sort of surgeries was it focusing on?
So the operating theatres at Guy's at that time were quite an interesting place to be. So Guy's was one of the leaders in this country for cardiac surgery, and the new techniques were just coming on stream at that time in the late 50s and early 60s, and so there were some very eminent cardiac surgeons particularly, and quite a lot of the major mistakes, or some of the major mistakes rather, occurred in patients having that sort of serious surgery. But the vast majority of errors, there are about 120 recorded in the book, and I think actually about 3/4 of them are very trivial. They're very minor errors. At that stage, there was a drug called thiopentone that was used an intravenous drug that was used to start general anaesthesia in most patients. Thiopentone is very irritant if it's injected outside the vein, and so if you're putting a drip in or putting a needle into a vein to inject and you're in the wrong place, you run the risk of putting some of this stuff under the skin before you've noticed it, and that causes pain and swelling and redness, and even worse on few occasions. And so quite a lot of the initial reports make fairly dull reading, because I put this needle in a vein and then I injected it and the patient said it hurt, and then I realised that I was putting the stuff outside, so I corrected it. I went back to the patient the next day and everything was okay. So obviously, there's not much to learn clinically from that. But
the next incident said ditto.
Yes, well, pretty much. Yes.
Especially they need more practice putting it in the vein.
So I think certainly over the 20-year period, it's quite marked that the frequency of reporting went down. So it was, as with all new things, people do it a lot to start with, and then people get used to it and go, oh gosh, that's all a bit of a bother, isn't it? And so the number of reports per year tended to decline the first year or two. There were lots and lots, and then fewer and fewer. But the severity of the incidents tended to go up. So there was a sort of, I suppose, a sort of self-selection by the doctors to include incidents that they regarded as important or relevant. And in one case, quite clearly, because they anticipated the possibility of some form of litigation. So although we regard litigation as a sort of modern problem, if you like, I mean, it's been around for an awfully long time. My period of study, I suppose, falls within the NHS era, and certainly at the time the NHS was founded, although nominally under the arrangements under which the NHS was set up, nominally the Minister for Health would take responsibility for errors occurring in hospitals. There was quite a lot of stuff around at that time. Doctors were concerned about how this would actually work, how would mistakes be dealt with, and who would be held to be responsible. So yes, so in terms of the clinical medicine, the latter stages of the book are rather more interesting than the first sort of 60 or 70 incidents. Everything starts to get more exciting and interesting after about the 1960s or the mid-1960s.
But not for the patients.
Sorry, yes. I'm
more
sorry.
traumatic.
Yes. Sorry, no, I meant interesting for me as a historian. I don't even mean interesting.
With no heart.
Yes,
it's great.
I don't even mean interesting for the anaesthetists concerned. We anaesthetists like a nice boring life. We really would rather nothing happened.
And just to clarify, it's incidents of the anaesthetist, not things that then subsequently went on in surgery.
No, so my work started with this book, which was written by anaesthetists. So obviously my focus on the details of the errors was very much focused on anaesthetic mishaps rather than surgical ones. I mean, quite often the two come together, but these were recorded by anaesthetists, so they're clearly written from an anaesthetist perspective. But as I said, Guy's has a magnificent archive, and it also has the world's longest running hospital magazine, the Guy's Gazette, maybe called something different now, but the Gazette is an absolutely extraordinary document. In the 1950s, it was published by medical students, incredibly professional, came out every couple of weeks. It was anywhere between 30 and 50 pages long, and it had absolutely everything in it, right from editorials about matters of the day, going through to the lecture timetables, going through to reprinted lectures or talks, going through to reports of the sport and the social life. It's a really extraordinary resource to look at about how medicine was practiced in those days, and the concerns that the doctors had. I mean, the medical error features quite prominently in the editorials, and I mean, it comes up quite often. So it's a very, very interesting read indeed.
Right. What do they do with the data that they were collecting with the incident book, besides put it in the library?
Yes, well, so that's quite difficult. So when I interviewed my anaesthetist from that time, when I had two anaesthetists, four consultant anaesthetists, two consultant surgeons, and two retired theatre nurses from that era, from 1955 to 74. And with each of them, I conducted two interviews. One was effectively an oral history interview. It was basically asking them for their biography in a sort of in an interview where I led them from one stage of their life to the other. The other interview was a semi-structured interview specifically on critical incidents, and one of the questions that I asked in that interview was, were you aware of this book for the anaesthetists, or were you aware of any other system for systematically recording critical incidents? That was the question I asked to the surgeons and to the nursing staff. And one of the follow-up questions was, where incidents were recorded, are you aware incidents were discussed and where practice changed as a result? So we focused very much on that aspect of things today. Understandably, as you said, the purpose of recording these things isn't to amuse historians several years later. The purpose is to try and make life better for patients if we can. So the answer was generally no. So in other words, in terms of people reporting their own incidents, I got very little in the way of a specific recollection of practice changing, except for one absolutely extraordinary incident, which I was asked to write an editorial about, subsequently rejected, invited and then rejected. Anaesthesia was the journal, if you would like to.
So can you tell us to it now?
I can, yes, I could take it. It would be a great joy to tell you about it.
Finally, it's my day.
So I contacted a number of very old people. I mean, most of my interviewees were in their late 70s and in their early 80s from that period. And one of them was a consultant anaesthetist who worked at the Royal Brompton Hospital as a consultant when I trained there in the early 90s. And he was an absolutely extraordinary chap, but he'd done his anaesthetic training at Guy's. And when it was very hard to find interviewees. I tried a number of different routes and called up people, and this doctor's name came up, John Simpson. And I contacted him, and I said, "This is what I'm doing. I'd like to interview you about your life and about medical mistakes. And so would you consent to that?" And when he responded, he said, "Yes, I'd be delighted. I have one mistake in particular that I think would interest you." And so when I interviewed him, there was a part in the interview where I asked everyone, is there a particular incident or incidents that you recall that you feel we might be interested to hear about in terms of its effect on you, its effect on patients, its effect on the way that the hospital worked. So John was a junior registrar. It's quite a junior training grade in the specialty, so he would have qualified and had perhaps a year or two doing anaesthesia. Yeah. And as I said, this was in the very early days of cardiac surgery at Guy's Hospital. There's some real sort of groundbreaking stuff going on. And it was also in the very early days of intensive care units. So these had not really been used before. Even patients having cardiac surgical procedures would be discharged to a sort of recovery area that was not very specialised. Yeah. But in the, I think in the late 50s and the early 60s, hospitals started to establish specific wards for the management of patients who'd had really major surgery that required rather more support than your average patient. And these had mechanical ventilators on. And John had received a child patient, a paediatric patient, who'd had a cardiac procedure and required ventilation on a mechanical ventilator for a period of time afterwards. And when he put the child on the ventilator, it became clear that the child turned blue, effectively, not deep blue, but bluer than it should have been, which is an indication that the blood is not correctly oxygenated. And there are a number of reasons why that might be, and so these were all investigated and thought about. It wasn't quite as easy to get exact measurements in those days. These days we have a clip that one puts on a finger to measure the level of oxygen in the blood. In those days they had to take samples and
is that what it does?
Yeah, there we are.
You've learned something.
Okay.
In those days, you had to take blood samples and put them through an analyzer, and every time you wanted a measurement, and it was rather a bigger deal than it is now. And it was clear that the child wasn't getting enough oxygen, so in the end the child went back to the operating theatre, was reopened, so they reopened the wound, explored the surgical site to make sure that there was nothing wrong with the work within the heart, and then they brought the child out again, put him back on the ventilator, and once again the oxygen levels went down in the blood. And some 24 to 48 hours after the operation, they'd had 2 changes of personnel. So John had gone home. I think the second or the third registrar had come on as part of the rotating on-call commitment. Yeah. And he discovered that the oxygen being administered to the child through the ventilator had been connected to the wrong limb of the ventilator circuit. So you would expect it to be put in the inspiratory limb, the gas going to the patient, and in fact it had been connected to the expiratory limb. And this was all behind the ventilator machine. It's all in the sort of guts of the ventilator where these connections are made. The ventilator was sitting against the wall. John had never received any formal training on the ventilator. There was a technician whose job it was to look after them in the intensive care unit, to look after the ventilators and make sure they were working correctly. So it was a sort of an error that had occurred. The child died subsequently, and John had a great tragedy for the child's family, obviously, and pretty unpleasant for John as well. And so there was a coroner's inquest at Southwark Coroner's Court, which is just down the road here. And during the course of my research, I was able to find the original coroner's file. These things are often restricted because of living relatives and so forth, but the coroner was kind enough to give me permission to have a look at the file and to take some notes from it. John was an ex-naval man, Royal Naval Volunteer Reserves, and he described the procedure as, "The coroner gave us a straight lashing." And they were not supported. So John, as I said, would have been just a few years post-qualification. They were not supported by anyone from the hospital. Nobody from the hospital turned up. So the 3 junior doctors appeared by themselves in front of the coroner. It was reported in the Telegraph. So I found the original article, 1967. It was reported in the Telegraph in not glowing terms. John told me in his interview that he had received hate mail, and he was basically told that future applications to work at Guy's would not be viewed favourably. So it really changed the course of his career. The 2 other registrars who were involved both left the country, so they made their careers elsewhere because they felt that they would have such a hard time. So as a result of that, I think I said before that I didn't find many instances where things had changed. The only thing John said that had come out of it that was good was various things that might reduce the chances of that happening to other patients in future. So he said, we all had a training session. Everyone said, okay, if you're going to be using this stuff, then you better know how it works. The technician involved was left and was replaced. And I think John is of the opinion that this was an incident that achieved sufficient national profile that the manufacturers changed the way that ventilators connected so that they couldn't be connected up the wrong way.
Right.
Now, I did some research into that area. I went to the Science Museum. I had a look at a ventilator of the sort that he'd been using and looked at some of the British standards that were published at around that time. I couldn't quite find the evidence that what he said was correct. It was certainly there was certainly a general concern about interchangeable circuits and how they might be dangerous, as indeed there is. There has been much more recently. I think we've begun to get that sorted out, but it isn't sorted out completely. And in fact, the reason I was asked to write an editorial was not purely about that case, but another case that happened in Oxford 2 years ago, which was the subject of a coroner's inquest there, which was a young woman in residential care who'd been on a different kind of ventilator, but where the nurse looking after the patient had not realised how to connect the circuit, and the patient died as a result. So I tried to use this in my article to highlight the things that have changed and the things that haven't changed, and to try and draw some lessons from that.
And that seemed quite easy to fix.
Yes, I suppose the problem is, so in the discussion for the article, I said that there are a number of things that have worked against. So most things have worked in a positive direction, but a number of things haven't. And one of them is the increasing complexity of equipment. And by that I mean the complexity of individual bits of equipment. So they're quite complicated things, ventilators, they're difficult to understand, difficult to put together. But also the variety of equipment. So back in John's day, there would only have been a handful of ventilators available. Now there are many, many more different types of ventilator. And one of the problems we have as anaesthetists when we move from hospital to hospital is that we quite often arrive and find, for example, an anaesthetic machine, which will normally contain a ventilator, among other things. The anaesthetic machine is not one that we see regularly. And so, certainly in my training, it used to be a moment of considerable anxiety the first time you arrive in an operating theatre in a new hospital and go, well, I've never used this one before. With the training, I suppose, has got more and more. We have become more and more rigorous about training people, but ultimately, because the NHS is driven by productivity, because you need people to be flexible, either to move from one theatre to another or one institution to another, you're looking at people who are exposed to many different types of equipment. So although the equipment itself may have become safer, the business of assembling it and training and all that sort of stuff has become rather more complex. I think one of the other problems too is that the classes of people, the types of people that use the equipment has changed as well. So it would have been pretty inconceivable in John's day for anyone other than an anaesthetic registrar or above to use the equipment. In the case in Oxford, the young lady who died was ventilated normally at home. And so her parents were very involved in it, and she had a nurse with her who was specialist trained in that particular ventilator. And in fact, when the young lady died in Oxford, she died in a residential home where she'd been admitted for some respite care. The diagnosis of misconnection just before she expired was made by the family. It was the father who said, that's not connected correctly. And so it was he who was able to move the connections around. So I think that illustrates the fact that with this very complex medical equipment, we are asking people who don't have the same breadth of training to look after things, which is fine in the normal course of events, but when things go wrong, you do sometimes need to have a bit of a broader understanding of how things work and how they go together. The nurse concerned in the Oxford incident had disconnected the circuit for cleaning and then reassembled it incorrectly. She'd left a bit out, a bit fallen off, and she'd reconnected it incorrectly. Wow. And so, a tragedy for all concerned, clearly for the family of the young woman concerned. I was fortunate enough to hear a recording of the inquest, and it was quite evident that the nurse concerned was pretty upset by it as well.
Of course, how could you not be?
Traumatic, isn't it?
I don't know, most people, even if after a while they become cynical, but most people go into it because they care, because they want to help, or because I don't know.
Yes. Yeah. I mean, I think that's a problem we're at, is that the vast majority of doctors and nurses and paramedical professionals and healthcare professionals in general are working with the best possible motives. They want to do the right thing, and I think that human error is a major cause of incidents in medicine and in every other area of life, really. And so I think it's hard to know what one can do about it. There have been great attempts made in the last 20 odd years, more still, 30 or 40 years perhaps, to try and develop systems in hospitals that make patients safer by reducing human error. But they're very difficult. It's very difficult to show that any of them work. And in fact, what you end up with is a very substantial administrative burden on doctors who are trying to look after patients, participating in a system to try and have errors analysed and to have effective action taken, where we don't really have any good evidence that does any good. Right. A lot of it comes down to a sort of common sense approach. It's very hard to show for a rare incident, for something that doesn't happen very often. It's very hard to show that any particular strategy is going to reduce the chances of that happening. Yeah. What you generally have to do is introduce the strategy and see what happens. Right. I suppose that's what happens in real life as well. Yeah. But
playing with people's lives.
Precisely.
Here, right? So I suppose, like you say, it's human error, but hopefully that people try to learn from them, and that's what you're trying to document, that people do learn.
Yes.
There are things to help.
Yes.
It's the best.
And I think the systems growing up which allow many more people to inspect errors and to see if they have a view on them. I think that has a downside as well. So the incident reporting was very much a thing in, I think, the late 80s in Australia, and in fact there was a large study called the Australian Incident Monitoring Survey, AIMS, and in those days the way that incidents was reported was anonymously. So doctors would write about incidents, submit the reports. They wouldn't name themselves. I mean, quite often it's easy enough to work out who's responsible. The incidents would be collected and reviewed at morbidity and mortality meetings, and recommendations made or strategies devised to try and reduce incidents. And the idea clearly was, if you collect all the incidents that happen, you can see patterns developing. But I think that the problem, there have been two problems since those days. The first is that we now don't do anonymised reporting effectively. The electronic reporting systems that we use now make a nod to it, but I think it's almost unimaginable that anyone with more than 2 minutes wouldn't be able to find out exactly who is responsible. So I think in a way that acts as a disincentive for people. Well, I know it does. The research clearly indicates that acts as a disincentive to people. I think the other thing doctors are wary of too is that most of the electronic systems now used by hospitals in this country allow the report to be automatically distributed to as many people as you like. And so we find now, typically, if I fill in a report about something that's gone wrong in my operating theatre, when I press send, I then discover that it's gone to anywhere between 15 and 40 people, most of whom don't work in my clinical area, and almost all of whom I won't know. And that itself is quite a disincentive. I had a very interesting interview going back to the historical research. Very interesting interview with a retired professor of surgery from Guy's, and he introduced morbidity and mortality meetings to the surgical department there for the first time in 1972, shortly after he was appointed. And his account of these meetings is absolutely extraordinary, because he said, people were, he said it was not something that he did without a little bit of worry, because he said, you were asking people to come forward for the first time and stand up and say what they'd done. Right. And he said he was greatly helped by one of the surgeons, who was a surgeon called Rex Laurie, who I think was a paediatric surgeon. And Rex Laurie was a very urbane, very charming man. And when my interviewee was talking about him, he said he managed to produce an atmosphere in the room that encouraged people to be honest and to say what they'd done wrong. I remember he described him as, he would say he would listen to an account given by a registrar who was getting very upset by what was done, and Laurie would say, "Oh, my dear chap, I wouldn't worry about that. I did exactly the same a couple of weeks ago." It sounds quite comical now, and it sounds suspiciously like a sort of medical club. It sounds as though we're doctors and we understand each other, and so But there is no doubt that sort of arrangement, if you are going to de-anonymise, that sort of arrangement does encourage people to be honest and encourage people to have a frank discussion about things with people who've been in the same place, who may have made the same mistake. Yeah. And so I think that more information is likely to come from that than the contemporary systems. I think the contemporary systems do generate significant amounts of paper. I think they are reassuring. It's nice for patients to know that there is a system by which errors are reported, that it's it's widely used. I suspect that patients might be disappointed were they to ask, "Can you show me that anything has resulted from that system that's improved patient safety?" So certainly those systems do generate through a system of morbidity and mortality meetings and review within the hospital and so on and so forth. Those things do generate changes in practice, but it's very hard then to show that those changes in practice have had any impact at all.
Right.
Back in the 1980s, the Australian incident monitoring system, I was working shortly after that in a hospital in Hong Kong. I was there for 3 or 4 years. And they are part of the hospital I was at was part of the Australian training system for anaesthesia and intensive care. And we ran a small study on having submitted incidents through the AIMS system. We ran a small study on whether things change or not. And we found that the only clear evidence we could find that that system produced changes with effects was in the matter of equipment. So if you have a lot of people saying that bit of kit doesn't work and this is how it goes wrong, it's easy enough to go, well, we won't use that bit of kit, we'll buy a different bit of kit.
Right.
And so that was a very definite improvement as a result of an incident reporting system. All the more complex things, there's no real evidence that there was an improvement by reporting them and thinking about them and talking about them. In particular, there was a phrase that was very popular at the time, which was raising awareness. So if you couldn't show that something had made a difference to patient safety, you could say it's raised awareness among doctors and nurses of the problem. And raising awareness is one thing, saving lives is a different thing.
I presume it's people report incidences when they go wrong, but if they happen and have a positive outcome, like someone suddenly goes, oh, I've spotted that the tube's in the wrong place, they change it and they're great and they carry on going. If I haven't got time or go, by the way, I did this and it worked. It's
there's been quite a lot of attention on that, on the business of near misses as being something which, it's important to report. So we are all encouraged to report near misses. I forget the definition now that is used for when things go wrong. Critical incidents was a term very much in vogue when I did my research, but we're changed to adverse events now, or serious adverse events. So they've all got slightly different definitions and so forth. But people are very concerned about near misses, and there are lots of we are encouraged, as I said, to report them. And in fact, in the young woman who died in Oxford, it was only at the coroner's inquest that it was revealed that someone had the same problem and sorted it out just a few weeks beforehand. Right. So I think that there is clearly benefit in people reporting these things, but I think the point you made earlier about the administrative load is a correct one. Most of the time we go, oh, thank goodness, spotted that was all right. Mm-hmm. Move on to the next. Whereas had it gone wrong, you would feel inclined, rather more inclined to report it, I think.
Yes.
And part of that is that you want to be seen to be doing the right thing. Doctors, the evidence is absolutely clear that doctors and nurses involved in incidents fear blame, and they fear not doing the right thing. And so many of us will report because we know that that's the right thing to do. Not in many instances, not with any faith that anything's going to change for the better, but we know that the system asks us to report, and so that's what we tend to do.
Yeah. And
in your role as a project manager for the Histories and Archives, what are you hoping to produce at the end of?
So that's a slightly different. Yes, I'm on a career break at the moment.
Oh, I see.
That has nothing to do with medical error, but a lot to do with history, as the name suggests. Right. So I was seeking a career break for a year, and I saw a job advert that I thought I might be qualified for. So anaesthetists do quite a lot of physiology. It's one of our core subjects. We understand it very well. We study it quite hard. And I got my experience with oral history recordings. And the Physiological Society has a large collection of oral histories, interviews recorded with eminent 20th century physiologists. And they wanted someone to do something with them. So one of my jobs is to go through the oral history collection there and try and find ways of getting information about physiology out to the public. So it's unrelated to the error thing.
Oh, right.
But the error project is continuing. I spoke at the National Oral History Society conference just a couple of months ago, and the members of the audience there were quite interested in what I've done with it. So they are academic historians. I've not had a large academic publication from this, but I've had a number of other things come from it. So during the course of my research in the Guy's Hospital Gazette, I found a mention of a 1958 film that won a British Medical Association award. And it was the second year the British Medical Association were running awards for educational films. This was a film made by one of the cardiac surgeons at Guy's. As I said, it's very, very early days of cardiac surgery. And for a very short period in this country, doctors were advocating open cardiac massage. So in the event of a cardiac arrest in hospital, the recommendation was to take a scalpel and open the chest. And so I did quite a lot of research around that area, and I found this film. It had been moved from one library to another, and I found it on celluloid in the Wellcome Trust. And the film curator there is a lovely woman called Angela Sayward, was really helpful, and she took the film out of the freezer. They keep them at a very low temperature to avoid degradation, allowed it to come up to temperature, and we watched it together. And it's the most extraordinary film. And we had a chat about it afterwards, and I said, is it due for digitisation anytime soon? Does the Wellcome Trust have a rolling programme of digitisation? And she said, well, not for a few years. And I said, well, I'm not sure I can stretch to the funds to pay for it. And she said, I'll tell you what. She said, if you write me a blog about your research to accompany the publication of the film digitally, then we'll do that. So I did write a blog. You can still see it. It's called Doctor, the Heart's Stopped, and it's about the history of open cardiac resuscitation in this country. Wow. And they published the film, and it's the most watched film that the Wellcome have put out, more than 500,000 views. Oh, so, and mostly because it's really graphic. But the interesting thing was that in the course of my interviews, one of my other interviewees, a retired theatre nurse, when I asked her to describe an account, she described an account where she had been nursing a patient after general anaesthesia for electroconvulsive therapy, and the patient had a cardiac arrest. And she described a first-hand account on an audio tape. It's an absolutely compelling bit of audio footage. She describes the consultant anaesthetist taking a scalpel from the windowsill and opening the chest in the ward, and recovering and the patient survived. And in fact, when I look back through the minutes, the committee minutes at Guy's Hospital at around that time, there's one fantastic entry where somebody brings up the issue of junior doctors with scalpels in their pockets slashing open chests. And in the minutes, it actually appears that in the last week there have been 3 in and around the wards. So for a very short time, that was what was being recommended. And then this was at about the time that closed cardiac massage was invented and external defibrillation was invented. And so it lasted for just a few years. As I say on my blog, the interesting thing is that all the objective evidence on cardiac resuscitation, which is examined very carefully by a body that looks at evidence in order to make recommendations to the Resuscitation Council for the treatment of cardiac arrest, they review the evidence on almost every aspect of cardiac resuscitation. And some years ago, not that long ago, they looked at open versus closed cardiac massage. And out of the 30-odd studies that they were able to find, most of them animal studies clearly, but out of the 30-odd studies, all but one were absolutely unequivocal that open cardiac massage is more successful than closed cardiac massage. And the only one that was dissenting said, well, we don't really know, we can't say. But as I said, 30-odd studies point at open cardiac massage, so opening the chest, putting your hand in and squeezing the heart directly, as being a more effective means of resuscitating a patient than not. And I think the reason it went out of fashion is effectively is a cultural one. Clearly the shock of having people sort of, have their chest out.
Go down in the first aid training that you have to do as a member of public.
I think probably not. So to my mind, the most significant thing that's come out, all this stuff is lovely and it's interesting and fascinating. As I said, the old films and the audio footage are really, really compelling to listen to and watch. I went on to get a grant subsequently from the Guy's and St Thomas's Hospital charity to work with a theatre company called Claude Ensemble, who have run for many years a very successful program called Performing Medicine. And they take their work into medical schools. They have an initiative which involves a number of medical schools and is about effectively training staff, trying to get them to think a little bit more about what they do and how they behave and how they respond to stress and how they deal with patients. There are a number of different strands to it. But they were interested in collaborating with me to try and design an event. And so, as I said, we got some funding to put on an interdisciplinary meeting. So we had about 50 invited delegates. We had doctors, nurses, lawyers, medical insurers, GMC, ethicists, priests. But most importantly, we had representatives from the two main patient advocacy groups, the Clinical Human Factors Group, led by a gentleman called Martin Bromley, who's very well known in anaesthesia. His wife was the victim of a fatal medical error some years ago. And so anaesthetists all know his name. He's a charming chap and absolutely he's an inspiration, real inspiration. And with a group called Action Against Medical Accidents. So they sent people along as well. And we had a meeting where some of the transcripts that I had taken, one from a retired anaesthetist and one from a modern day anaesthetist who at that stage was under investigation by the GMC, completely exonerated, but was going through the process. And the theatre company employed a playwright and a director, Jude Christian, and they created a short piece, 5 or 10 minute long piece based on the transcripts with two actors performing it.
Oh, wow.
Which was quite extraordinary, really. And we also had a visual artist called Sheila Galani who took some of the artifacts that we'd collected and some of the information and made some art from it, made some pieces based on the project. But the most significant thing was the discussion around the theatre piece and the conversations that emerged. Martin Bromley interviewed live in front of the audience another patient who had been a victim of an anaesthetic error, and that was really compelling because clearly the majority of the audience, so it was interdisciplinary, the majority of the audience were connected with hospital medicine in some way. And to hear a patient describe what had happened and how she felt and her attempts to resolve her feelings about the incident, which had not left physical damage, but she suffered from post-traumatic stress disorder. Her account of how she dealt with it all was quite extraordinary. She had, I think I'm right in saying, she had sat on stage in a live conversation in front of a medical audience with the doctor who had been responsible. And so what I'm hoping, we tried to take that forward a little bit. So Jude Christian has spoken to the Royal Exchange Theatre in Manchester, who for a while were interested perhaps in developing the work. And these things all cost money, and so that hasn't happened yet. But I'm very much hoping that I'm going to be able to devise ways in which patients can have the opportunity to have slightly more frank conversations with doctors and hospital staff when things have gone wrong. And I suspect that that will be facilitated by some recent changes in legislation. So hospitals are, in the last few years, have been obliged, I think under the Coroner's Act, 2009 Coroner's Act, to appoint medical examiners. And so these are doctors working in the hospital. The concern was that the death reports that were coming from hospitals were not sufficiently accurate and that patients were not sufficiently involved in discussion and process and so on. So the idea is that medical examiners will be looking at deaths in hospitals, will be responsible for setting up systems to explain things to patients and to have conversations that perhaps work rather better than they do at the moment. So I'm very much hoping that perhaps my work will feed into that a little bit. So they've just advertised the Chief Medical Examiner post at Guy's and St Thomas's. So they're setting the service up at the moment, but once it's up and running, I shall be back in the hospital. I'm hoping very much to have some sort of input into that.
Do you think it would be useful to have some kind of intermediary between... Some patients might be nervous to talk to a doctor about it, to ask questions that they think, well, actually, I probably should already know that because I'm so far down along on this journey of my illness. I should have picked up something else, but I'm still not quite sure what's happening here. And so, would it be worth having an intermediary, do you think, between?
Yes. Well, I think that's probably a good idea anyway. In many areas of patient care, I think that particularly in connection with medical error, I think that that's a great idea. And one of my concerns, I've tried a number of different ways of putting myself in a position to set up this sort of system in the best way I can think, which would be ideally you wouldn't choose anyone connected with the hospital where the error had happened. And I think that's one way that you would convince patients of the goodwill behind the process and the attempted objectivity behind the process. I think the other thing too is an idea that I've not really talked to anyone about, which I think is perhaps there might be a way in which not only do you have an independent medical person having the conversation, but you have a patient advocate having the conversation as well. So in the room you might have the patient or the patient's relatives in the event of a fatal medical error, a medical representative from the hospital, in which the error took place, but then two other people in the room, a sort of independent medical interpreter, if you like, and a patient advocate as well. And I think there are plenty of models in law about mediation and in other areas as well, where I think that sort of conversation could work really well.
People have stepped away from it emotionally.
Yes, exactly. Yeah, I think there has to be a bit of distance. I don't mean insensitivity. I mean that to a certain extent, if proper explanations are to be given and situations are to be managed in a sensitive fashion, I think one has to pull back a little bit from the blame for a bit and try and establish what's gone on and explain how things have gone wrong. And so, as I said, I'm hoping that that may be one of the outcomes.
Do you want to tell us how you got to your career to this point? How did you sort of work up to here?
Oh, yes, certainly. So...
Or did you have a particular... Did you always want to be an anaesthetist?
No. I'm. When people ask me what sort of doctor I am, I say a reluctant doctor. So I've always sort of tried to seek interesting areas of medicine or science to relieve the mundane aspects of the daily work. So I started training as an anaesthetist fairly soon after I'd done my houseman's year, and 6 months in casualty, and then I started training as an anaesthetist, and that took me 8 or 9 years. I went to Hong Kong for a few years as a lecturer, so I had clinical obligations there and a day a week of research time, and I became interested in the measurement of the depth of anaesthesia. So it was up until 20 years ago, there were very few reliable methods of assessing whether someone was asleep or not. The methods were reasonably reliable, but they relied rather too much on subjective judgment. And so people have been struggling for many years to try and develop some sort of brain monitor that you might apply to people during a general anaesthetic to be sure that they were asleep. And the reason that's important is that we have a family of drugs that we use to stop the muscles working during operations for one reason or another. And the scenario that appears from time to time in the papers, particularly the more florid ones, is a situation where patients are not unconscious, that they remember stuff, but cannot move because the muscle paralysing agents are working. And that situation arises for a number of reasons. it's very rare. So aware that this is a major source of concern and worry for patients. It's probably the second most common question we get asked, other than am I going to survive? So am I going to be awake during the operation is one that greatly concerns patients. So the Royal College of Anaesthetists and the Association of Anaesthetists of Great Britain and Ireland got together some years ago and did an enormous national survey over the course of a year to try and establish how common it is, and the answer is it's about 1 in 20,000. So it's pretty rare. Most anaesthetists, jobbing consultant anaesthetists, probably anaesthetise about 500 cases a year. So you're talking probably once in a career for most anaesthetists. And it arises from a number of different things: decreased patient sensitivity to anaesthesia. So we suspect that some patients their brains work a bit differently. Everybody's brain works differently, but in some cases their resistance to anaesthesia may be greater than other patients. Human error, equipment failure. So these are all things that feed into them. So in the 90s, in the mid 90s, someone invented a monitor that they thought was likely to be better than the other ones available, and that was developed in the US. And so I was involved in quite a lot of research at that time in the early days of that monitor, and so I became very interested in consciousness and in general anaesthesia and the characteristics of it and how one might measure it and the effects on the brain. And as a result of that, I moved into. I came home from Hong Kong, took up my consultant job here, and then 5 years later had the research idea that I should have had when I was in an academic post, and I thought that I could answer the 150-year-old question: how do general anaesthetics work? We still don't really know, and we know rather more than we do 20 or 30 years ago. But I hit upon an idea that had not really been used before. There was one small study group that had done something similar, but not at the same sort of scale that I was proposing. And so I looked at a large number of patients, about 800 patients, and I measured very carefully the amount of drug that was required to render them unconscious, and I had a very clear definition of what I meant by unconscious. And I then took DNA samples and examined them with respect to one particular gene that codes for a neurotransmitter in the brain. And my hypothesis, if you like, was that differences in sensitivity to the anaesthetic drug might somehow be related to differences in the genetic makeup with respect to that particular gene. And if I could show that, then it was very good, or it was circumstantial evidence that gene, that neurotransmitter, was the one that was important for the action of the anaesthetic. Like all grand quixotic schemes, I didn't find the answer. There wasn't a positive result. Close. I got quite close statistically, but unfortunately that particular methodology of study, taking one gene and looking at it and trying to see whether variants in one gene influence a very complex phenomenon like consciousness, that's very much gone out of fashion now. There are quite profound statistical concerns about it, and in fact when I was trying to seek help from the geneticists at the start of the study in 2004 or 5, some of the more cautious ones were already saying, this is, we can see where you're coming from, and this 10 years ago, this would have been, we would have leapt at this, but the funding is moving away from that sort of study now because people are starting to be a little bit concerned that the results are often not reproducible. So you'll find that one group will do the study and another group will do the study as near as damn it and find something completely different. And the statistics of genetic association are quite complicated, and they've developed hugely in the last 10 years since I did my doctorate. So I did get a doctorate out of it, which was great. The thing that really came out of it that was fantastic, and that's what started me really on my journey through the arts and to history, was another genetic study. So while I was trying to get money for my genes and anaesthesia research, I went to see a friend of mine in the arts, and it was Easter Sunday lunch sometime back in the mid-2000s, and I was saying, I can't get money for this, and I'm gone part-time, I'm doing all of my own time, someone's got to pay for the actual gene testing, and I haven't got any money for it. And she said, you need to come up with some science and arts genes thing, because there's loads of money in the arts for that sort of thing. But it turned out that she wasn't actually right. But in the car on the way home, I had a little light bulb moment, and I was listening to the radio, and I said, I've been looking at genetic predictors, if you like, of anaesthetic sensitivity. I wonder if anyone's ever done genetic predictors of musical ability, or what things might be associated with musical ability. Because I'd done a little bit of genetics back as a med student, and I'd learned a great deal more during the course of my doctoral research. And I thought, well, that's quite interesting. So I phoned up my arts friend, and she said, you know what? Mostly when arts bodies give grants out, they expect some sort of arts outcome. So you're going to have to come up with something better than that. So I thought about it some more, and I thought, looking at gene sequences, they've only got 4 letters in, T-A-C-G. I bet someone's written some music based on gene sequences. And I went online and found that was very much the case. There were thousands and thousands of websites with gene sequences that have been converted to melodies. And there was even a website where you could select a bit of gene. You could type in your own gene or you type in any genetic sequence that you wanted and have it converted into a melody as a piece of software. And then I thought, well, I wonder if anyone's ever written a piece of music where the performers themselves are singing something that's directly related to their personal genetic makeup. Ooh. And nobody had done it. So I said, okay. And very few people had done anything on genetic variance and association with musical endpoints, because it's not health related. So it's really easy to get that stuff if you're going to make patients better, not for matters of purely scientific curiosity. Yeah. So I applied to the Wellcome Trust, not for a science grant but for an arts grant, and I got together with a composer and the poet Ruth Bedell, who has a long history of collaboration with scientists and is a great poet. And so we got together and we cooked up a project that had 2 arms. I did my study on choirs. So I took 250 singers in choirs. I took all their DNA. And I took 250 people who professed to have no musical ability at all, mostly selected from doctors, anaesthetists in particular. And so I did my study looking at genes relating to 2 neurotransmitters that I thought might be interesting. Serotonin transporter being one, and an arginine vasopressin receptor being another. So they're both receptors in the brain that I had reason to believe might have something to do with musical aptitude or musical phenotypes, musical qualities. In the meantime, of those 250 choral singers, 40 of them had allowed their DNA results from the analysis to go to the composer, and he then wrote a 40-part choral work in which at one point each singer is singing their personal genotype in relation to those genes. Really? And so we had, it was a lot of interest, so we were all over the press, Today programme, Nature, all kinds of things, Pick of the Week, Radio 3, Radio 4, Radio 6, Cheltenham Music Festival. Cool. So it was a great success, it was great fun, and Michael Zev Gordon, the composer, won a national award. He won Composer of the Year for choral work that year with our piece. So we had great fun with that, and the best thing for me was that I got a positive result from the science study. So I did find that the people in the choir were different from people who weren't in the choir. So they differed in one respect. when I talked to my genetic collaborator, Professor Catherine Lewis, who's a genetic statistician at King's, when I talked to her about this, she said, you have to be really careful about this stuff. And certainly while we were putting it all together, there was quite a lot of media interest as the project went along. We went for a conversation with the BBC, see if we could pitch them a documentary on it. And the first question the commissioning editor said to me was, are you going to find the musical gene? And I had to explain that genetics doesn't really work like that. That for something like musical aptitude, there are many, many, many different aspects of it, each of which probably has tiny, tiny influences from hundreds and hundreds of genes. So, effectively the message I gave her was, I don't think the results of my study will enable you to cancel the clarinet lessons for your daughter, right? Because you've got the wrong gene variant. It's not going to be like that. So we had. It was a very, very interesting time, very rewarding. The piece of music's great. You can listen to it online. It's the project website's still up. It's called Music from the Genome, and the piece is called Allele, Allele. It's very striking. It's a beautiful piece of music. So that went on to. So I did the music project. Then I did then I collaborated with the Science Museum on. I had an idea that the Science Museum probably had never done an exhibition about anaesthesia, and so I went to talk to them, and we applied together for a large grant from the Wellcome Trust, and out of that came an exhibition called Painless back in 2013, I think, which ran for a year at the Contemporary Science section of the Science Museum. And then from that, a few other bits and pieces, lots of applications, many more applications than successes. That's always the way. But eventually that culminated in the big application to the Wellcome for the project on cultural aspects of consciousness, cultural and scientific aspects of consciousness. And that's where I met my historian, and that's where all the history.
If you had to sum up why your research is important for the public, you do it?
I think both patients and doctors feel that the way we deal with medical error is not right, and it's fantastically common. There's an oft-quoted paper for medical error in the UK that suggests it contributes significantly to 1 in 10 hospital deaths. So it's potentially a huge problem. Another paper from the US suggests 100,000 deaths every year due to medical error. So it's a massive problem. I don't think I've got the answer. I don't think I'm going to stop it happening. But I think that some sensible conversations in individual cases might go some way to rebuilding relationships between patients and doctors.
Well, thank you very much, Andrew. Thank you for talking to us today. It's been really great.
Great pleasure.
Thank you very much to everybody for listening. We'll put links up on our website, which is antiwafflepodcast.wordpress.com, and our Twitter account, which is @antiwafflepod. Please do get in touch, as we'd love to hear from you. Bye.
Bye.